Hi everyone, thank you for joining. I have Dr. Shannon Gwynn with us who will be presenting her study. Over to you, Dr. Shannon.
Hello to everyone who's able to virtually attend. Thank you so much for your interest in this topic. We're going to go ahead and play the pre-recorded presentation of my slides, and then afterwards we'll take questions live. Either type them in for the Q&A or raise your hand and they will virtually connect us. So I think we're ready to get started. So Bangi, do you start the presentation? Hello, and thank you for attending this presentation entitled Delivering Adolescent SBIRT as part of a cluster randomized trial in rural U.S. health centers. The focus of my talk today is on provider fidelity to delivery of the adolescent SBIRT intervention. My name is Shannon Gwynn Mitchell. I'm a senior research scientist at Friends Research Institute in Baltimore, Maryland, in the United States. And I'm honored to be presenting this as part of the 2021 Inebria conference. The research I'm presenting today is funded by the Conrad and Hilton Foundation and is registered on clinicaltrials.gov. I want to acknowledge my team members at Friends Research Institute. Dan Brzezinski, Laura Monaco, and Mishka Turplin are my co-investigators on the study. In addition, our study RAs, Kron, Caitlin, Gustavo, and Tyler, who worked with us over the course of several years while we gathered data for this study. And then, of course, our clinical partners, Hidalgo Medical Services in New Mexico and Lifespan Health in Tennessee. The work I'm presenting today could not have been possible without their assistance and hard work. So according to SAMHSA, SBIRT is an approach to the delivery of early intervention and treatment to people with substance use disorders and those at risk of developing those disorders. So just by definition, we're talking about a continuum of illness as well as a continuum of potential interventions and help that could be provided. As SBIRT researchers, however, we typically focus on sub-elements that go into SBIRT. We focus on finding the right screening instrument based on the population that we're studying or the settings in which they're going to be administered. We focus on specific brief intervention techniques and how they're delivered and how they might change behavior in terms of acceptance and understanding. But when we break it into those sub-elements, sometimes we miss the essence of the continuum of services that really are at the heart of what we're trying to do. So in response to this, the Facilitating Change for Excellence in SBIRT, or the FACES intervention, was developed specifically with input from experts on adolescent SBIRT in the United States. So the National Council on Behavioral Health convened a group of experts who brought in evidence-based screeners and brief intervention techniques and helped them develop this particular what was called a change package that was tailored for use implementation in primary care settings. So it was specifically focused on delivering SBIRT in primary care. As I mentioned, the elements that went into developing FACES were evidence-based, but the comprehensive intervention itself was untested. So the Conrad and Hilton initially developed funding for the development of this particular change package, and then they brought in our team at Friends to come and conduct a comprehensive clinical trial comparing youth who received the FACES intervention with those who did not, to look at the effectiveness of it. So this was an opportunity to actually test it in a clinical setting, which is where it was intended to be delivered, but also to look at SBIRT across the continuum of care. Again, these were adolescents from 12 to 17 years of age, and they were going to be reporting a broad range of substance use. The FACES change package includes the S2BI as the recommended screening instrument, so the screening to brief intervention. So it asks, in the past year, how many times have you used tobacco, alcohol, or marijuana, the big three? And if the youth endorse never, then the screening is over. And as you can see at the bottom of the screen through the S2BI algorithm, if the youth reported no use, they were supposed to be receiving anticipatory guidance from their primary care provider, acknowledging the fact that they were making healthy choices, opening up the conversation so that the youth felt like this was a conversation that they could have in the future, and then obviously trying to establish some rapport with the provider surrounding this particular issue. If they endorse once or twice, monthly or weekly, then the additional questions were asked about prescription use, illegal drug use, inhalants, and such. And then based on if they reported use once or twice in the past year, they were to receive an abbreviated brief intervention. So the first 3 steps of the intervention itself that was detailed in the FACES change package, or if they report a monthly or weekly use, they were to receive the full brief intervention. So there was the continuum of interventions that were specifically tailored to the use that was reported. In our trial, as I mentioned, we had 2 clinical partners, one in Tennessee and one in New Mexico. And across these 2 federally qualified health centers, both in very rural communities, one in the Southwest United States, one in the Southeastern United States, there were a total of 5 different clinics, and we recruited patients who came in, patients 12 to 17 years of age, who came in for either a well child visit or a sick visit. Then depending on the provider that they were scheduled to see for that visit that day, they either received standard care or they received the FACES intervention, and they received the appropriate endorsed. Over the course of our trial and up to the point at which these data are presented, there were a total of 1,239 adolescent patients that we had recruited into the study who saw one of these 20 providers, 14 of whom had been trained to deliver the FACES intervention by last February 2020. So the focus on the presentation today, it includes all of those kids that were seen over the course of the study up to February 2021, of whom 938 actually had seen an untrained provider, so they received usual care, and 301 saw a FACES trained provider. And what we did for this particular study is we compared the screening results on the S2BI with a provider checklist. So at the end of their visit, the provider indicated what they did in response to the screening results and whether or not they had indicated a change plan or tried to make a change plan with you. Just looking at the characteristics of the patients that were in our sample, those roughly 1,200 kids, there were some significant differences between participants in these 2 states, New Mexico and Tennessee, based on gender, race, and ethnicity. So our Tennessee sample was predominantly female, 57% female versus 47% in New Mexico. The Tennessee sample was also predominantly white, 88% identified as white and 44% identified as white in New Mexico. And The majority, 69% of the patients who were seen in New Mexico identified as Hispanic ethnicity. In terms of substance use reported at baseline across all of our patients that were recruited into the sample, again, 12 to 17 years of age, and we were asked about past year use. 19% reported using tobacco in the past year, 20% reported using alcohol at least once in the past year, and 16% reported using marijuana at least once in the past year. So once we look at the screening results, those who did endorse some sort of use or said that they had not used in the past year, we compared those screening results to the checklist where the provider indicated what sort of intervention they had delivered. 98% of the patients who reported no substance use in the past year received anticipatory guidance, so very high fidelity to that intervention. 76% of the patients who reported past year substance use received some sort of brief intervention. So either an abbreviated or a full brief intervention. Of those, 77% received an abbreviated brief intervention, 49% received a full brief intervention, and 9% declined to receive an intervention. So the provider basically asked if it was okay to have the conversation about the screening results and to talk about it, and the youth had the opportunity to decline, so 9% declined. Of those patients who received a brief intervention, 53% had a documented change plan. So the provider didn't just talk about it, they talked with the youth about what they might want to change, whether or not they were interested in changing, and they documented that as well. So very encouraging results. Basically very high levels of provider adherence to the intervention delivery, particularly robust when the screenings were negative. So anticipatory guidance is a fairly brief conversation to have, and potentially a much easier conversation to integrate into the course of an already planned well child or an acute care visit. The FACES change package does permit for providers to use their clinical judgment. So while there is an indicated intervention based on the screening results, based on various factors going on with the patient, or what the provider is able to deliver at that time, they can use their clinical judgment and modify what they do at some point. So when we go in and we actually analyze outcomes, we'll look both at what was indicated should have been delivered, as well as what the provider ended up delivering, and then we'll use that to help us interpret outcomes. So we need to take all of those factors into consideration when we're looking at our final study. Thank you so much for your time and interest. Our main outcomes paper was submitted this past summer to the Journal of Adolescent Health as part of a special issue among all of the Conrad and Hilton Foundation awardees. And we're looking forward to disseminating more broadly findings from our trial. Thank you so much. Great, thank you so much for your time. I see we have a question. Hi, Jennifer. Is there anything known about the effectiveness of anticipatory guidance for adolescents? I wish. So one of the aspects of our study was that we trained providers in a stepwise fashion. So some of the participants that we have in our sample were potentially eligible to be recruited again after a year. And given that the preponderance of 12 to 17-year-olds are going to be reporting no use particularly at an earlier age, and we were going to be able to follow them over time, we actually hoped to re-recruit, and we did re-recruit some youth a year later, and who had received anticipatory guidance, and the hope had been to actually compare their outcomes um, at a later point. Unfortunately, COVID happened, and we were only able to recruit about half of the participants that we wanted, and we were never able to get back in the clinics after March 2020, which inhibited our ability to recruit and look at some of those longer term impacts of receiving anticipatory guidance. So it's an area that I actually think is ripe for investigation. If we really think about adolescent SBIRT in primary care settings, particularly with younger adolescents, what are the potential benefits of having this kind of a conversation and opening the dialogue with patients who are younger? Does it actually facilitate preventive discussions, and is there potentially a preventative effect of anticipatory guidance relative to just not screening someone until later adolescence? Unfortunately, we're not going to be able to answer those questions, but I would love to pursue that as an additional sub area in terms of this topic area, because I think there's a lot we want to know if we really do look at adolescent SBIRT and this continuum of both risk behaviors and intervention, understanding how to address and open the dialogue with youth who are not reporting substance use, any sort of substance use at an early age, and actually addressing it in a very brief way, so that it's probably not impacting and adding a lot of undue burden to the provider. But if it is shown to have a preventative effect, I think that's really profound and is something we should be looking into further. Let's see. COVID definitely made my amen. I really do hope that it's something that we can look into, because I think it's just really, it's something that lends itself so beautifully to this SBIRT model. And when we're talking about young people, I know we really tend to focus on who is really demonstrating or admitting to some sort of substance use, and how does the brief intervention facilitate potential awareness raising and commitment to reduce risk factors. But the potential preventive benefits of adolescent SBIRT are, I think, could be very significant, and in terms of cost effectiveness, a really important area for future study. Can you just establish? I think I talked a little bit about it in terms of the issues surrounding COVID early on. So this was a step wedge randomized trial, and the organizations that were involved, these two federally qualified health centers in rural settings in the United States, had decided they wanted to participate, but getting provider time to complete the training was a challenge. All of it was done virtually. This was pre-COVID. These were excellent trainers with prepared materials. The trainings were condensed, but getting the trainers or the providers trained and fitting it into their schedule was a challenge. But once that was probably the biggest challenge that we faced, was getting everyone trained. And as I said, it was a step wedge design. The last few cohorts were still in the wings, ready to be trained when COVID happened, which is, eventually all of the providers were going to be trained, and we were going to roughly equal out the intervention and the control arm participants. But because we were never able to get everybody trained, we do have a much smaller sample of youth who did receive the control condition, that did receive the intervention condition relative to the control condition. So that was trying to do it and build capacity in such a way that once the study was done, they had all of this expertise in terms of adolescent SBIRT training within their organizations was the goal. But we never achieved that goal. That feels like a failure, but it is what it is. I think it was the right design to do, given the fact that we were hoping that there would be some building capacity and sustainability at the end of our project. I don't know if we have more time or more questions.
Thank you, Dr. Shannon. So thank you for your presentation and taking all the questions. I think that's all the time we have, but it was really insightful to hear from you today. Thanks everyone for joining us. I hope you also had a very interesting day, and we will see you tomorrow for our last day of the conference, and I hope your sessions have been going really well. Take care, and thank you for joining.
Bye, everyone.